Hi everyone, my name is Audrey, and this is my presentation on Volkow and Blanco's 2023 article titled Substance Use Disorders, a comprehensive update on classification, epidemiology, neurobiology, clinical aspects, treatment, and prevention. So it basically covered everything under the sun. But I will just be going over the first 10 pages of the article. So I have a brief outline. I'll be covering classification and prevalence, neurobiology, risk factors, and clinical aspects. So the definition of substance use disorders in the article was patterns of substance use that harm psychological or physical health and or cause clinically significant functional impairment or distress. And diagnosis of substance use disorders is typically made per one of two classification systems, either the ICD-11 by the World Health Organization or the DSM-5 by the American Psychiatric Association. In terms of the ICD-11, it divides substance use into three overall categories. First is episode of harmful psychoactive substance use. Second is harmful pattern of psychoactive substance use. And third is substance dependence. The first two categories are pretty similar, have pretty similar criteria. It's basically just if the use of the substance causes damage to either the individual or others around them. Except the difference is the first category is based on episodic use or like one-time use, and the second is a harmful pattern going on at least 12 months if episodic, or at least 1 month if continuous or daily. The third category is kind of the most severe of the three, and it requires at least two out of the three following criteria. Number one, impaired control over use. Number two, use continues or escalates despite negative effects on other areas of life. Three, physiological features indicative of neuroadaptation to the substance, such as tolerance or withdrawal. And also features need to be present for at least 12 months, but one can also make the diagnosis if it's continuous for at least 3 months. And there's also classification according to the DSM-5. I think we're all more familiar with these, so I won't emphasize them as much, but it's generally a lot of the same criteria. The substance being taken in larger amounts than intended over a longer period of time, cravings, spending a lot of time trying to obtain the substance, tolerance, withdrawal, etc. And there's also some specifiers for severity. The article also covered prevalence of substance use. So the prevalence of substance use without being a full disorder, in terms of that, the top substance globally is alcohol, with about 40% of the global adult population using it. There are also large differences across countries in this, with a range of 80% to less than 100%. And the highest global prevalence for substance use disorder by substance puts nicotine at number one, with about 20% of the global population. And number two is alcohol, number three is opioids, and number four is cannabis. And these prevalence estimates are also generally greater for men versus women, with it being 2.3 to 1.5 times greater for men. And additionally, in terms of country, the highest rates for drug use are number one, USA, number two, Canada, number three, Australia, and fourth is the UK. In the US, one note on prevalence to highlight is that in the past approximately 20 years or so, there's been the opioid epidemic has been ongoing, and this has been a major public health crisis, especially given the high lethality of opioid overdoses, which is especially driven by illicitly manufactured fentanyl being mixed into opioids on the street, like heroin, for example. And fentanyl is a very powerful acting opioid. So this greatly increases the risk of opioid overdose. And the estimated mortality due to opioids in the US in 2021 was 81,052. So dopamine is a key neurotransmitter involved in substance use, including impacting motivation, incentive salience, prediction error, and associative learning, aka conditioning. And all addictive drugs increase dopamine in the nucleus accumbens, and these increases are greater and last longer than those from natural rewards. So it's easy to see how someone with addiction would might lose interest in non-drug rewarding stimuli, like spending time with friends, for example, because suddenly it's not as rewarding as the drug itself. And so addictive potential is determined by the magnitude and speed that the drug gets to the brain chemically. And this magnitude and speed are impacted by the type of drug as different molecular targets and mechanisms for each different drug. So for example, methamphetamine has the biggest increase in dopamine with 50% risk of addiction within 2 years after initial use. And also, the route of administration impacts speed. So, for example, injection and smoking both create a higher speed for the chemical getting to the brain than snorting or oral consumption, for example. So, if you can see here in this picture, hopefully the font's not too small, the part of the brain that's being highlighted, the little red dot in the middle, is the nucleus accumbens. And at the first exposure to a reward, drug or natural, but we're going to focus on drugs, the dopamine neurons fire in the nucleus accumbens. And then after many exposures of the drug then becomes an expected reward. And with this, the dopamine also increases in the nucleus accumbens in response to drug cues, such as so that's like other stimuli associated with the drug. That might be the setting where one uses, or the friends one's around, as exemplified by the image of the house and the little stick figures in the slide here. So those are drug cues that would also increase the dopamine in the nucleus accumbens. And this process of the dopamine only firing in response to the drug, going from that over to also firing in response to drug cues, that's known as conditioning. And that is very important, a very important process in the development of addiction, given that number one, it makes remission and abstinence a lot harder because suddenly you have all these um, cues around you triggering craving and wanting the drug. And also, when one uses in response to perceiving those drug cues and feeling the increasing the dopamine and feeling the craving, and so one then uses, that's reinforcing the link between the drug cues and the dopamine and the craving. And additionally, just the more that one uses, the more drug cues one, uh, you know, gets those associations with, so the harder it gets. So in terms of the transition from um, subclinical substance use to like a clinical substance use disorder, there are kind of three stages involved in that, and it's kind of a repeating cycle, and that's intoxication, withdrawal, and craving. And in these three stages, there are brain networks that are disrupted in each of them, and they get disrupted in different ways in each of these three stages. And those four brain networks are the reward network, executive control network, salience and emotion network, and interoceptive and default mode network. So in terms of the reward network, the parts of the brain involved in this are the midbrain dopamine neurons and their projections to the nucleus accumbens, dorsal striatum, medial prefrontal cortex, and anterior cingulate cortex. During intoxication, this reward network is maximally stimulated. During withdrawal, this network is hypofunctional, so there's decreased motivation and lower sensitivity to non-drug rewards. And additionally, combine this anhedonia with exposure to drug cues, and you have craving. And so lower sensitivity to the drug's pleasurable effects leads to a needing higher doses for the same effect as before. Or, as we all know, that's increased tolerance. And thus one may also use to avoid withdrawal instead of just to feel pleasure. And like I mentioned earlier, it's also associated with low interest in non-drug activities that would normally be rewarding, but not so with this hijacked reward network. And finally, research has found that increased sensitivity to drug cues is associated with substance use disorder severity and poorer clinical outcomes. So looking at the executive control network, this is involved in cognitive processes like self-regulation and decision-making. And impairment in this network is associated with difficulty resisting cravings, avoiding risky behaviors, and delaying gratification. And multiple areas of the prefrontal cortex are involved in this network. And during the intoxication and craving stages, there's activation of the ventral and medial prefrontal cortex, which is associated with salience attribution. And during the withdrawal stage, there's lowered activation in the ventral and medial prefrontal regions, as well as in the dorsolateral prefrontal cortex, which is involved in decision making. And third, we have the salience and emotion network, which the brain regions involved in this are the extended amygdala, the hypothalamus, habenula, don't know if I'm pronouncing that correctly, anterior cingulate cortex, and hippocampus. And during withdrawal, there's greater sensitivity of the salience and emotion network. And this network could also help explain a bit about the comorbidity of substance use disorder with anxiety, depression, and suicidality, especially given the role of negative affect in substance use and the self-medication hypothesis. And last but not least, we have the interoceptive and default mode networks. The interoceptive network is involved in shifting us between flexible and goal-directed behaviors versus reflective and compulsive behaviors. And the insula is the part of the brain really involved in this. It integrates information about internal states and sends that information to parts of the brain involved in decision-making, reward, and salience attribution. And activation has been associated with drug craving. Additionally, there's the default mode network, which is involved in self-awareness and mind wandering, which is a very important mental ability. And during the craving stage, there's activation of this network. And with drug use, there's disruption to parts of this network, including connectivity and activity in the anterior insula, cingulate cortex, and precuneus, another hard word. Next, we're going to look a bit at risk factors. First, in terms of development, a lot of the developmental risk factors have to do with the delayed maturation of the prefrontal cortex. First, there's developmentally normative, so healthy delay in maturation of this cortex. It's not typically fully developed until one's mid-20s. But what that means is that individuals who, or adolescents, are at a greater risk for experimentation with drugs, and so that could put them at risk for later drug use. Additionally, there are some not normative things that could cause delays to the prefrontal cortex. So if one experiences social stressors in childhood, this could increase the risk of substance use in later adulthood, with the mechanism being the social stressors in childhood could like impair the functioning of the prefrontal cortex, which then increases risk for substance use in adulthood. And additionally, if one is exposed to drugs in early adolescence, that could damage the prefrontal cortex and again, increase risk for later drug use. And research supports the association between substance use disorders and damage to the prefrontal cortex in adolescence. We also have social environments as a risk factor. The risk for substance use is associated with environmental stressors, availability of drugs, low social support, and a dearth of opportunities and sources of positive reward. And effects are especially pronounced when the stressors are experienced in childhood due to brain development. And this also connects to a previous reading of ours, I believe is the first one in this course, the Sinha 2024 article that had a really, I don't want to say exhaustive, but like a really good list of the ACEs, traumatic events, social determinants of health, and stressful internal states. and really connecting those to substance use disorders. Additionally, we have genetics and epigenetics. It's estimated that about 50% of risk for addiction is due to genetic factors. Um, and some common genetic factors underlying this are externalizing and internalizing predispositions or like proneness to that due to genes. And this can help explain some common comorbidities like ADHD with substance use. There could be a genetic predisposition for impulsivity, for example, and internalizing genes. It could underlie the comorbidity of substance use with like anxiety and depression. There are also gene variants involved in alcohol metabolism, which have the largest effect of all the gene variants. And also genome-wide association studies reveal that addiction is a polygenic disease, which is influenced by multiple genes and genetic networks. Additionally, based on preclinical studies, so animal studies, it's believed that epigenetic modifications underlie the neurological changes associated with addiction. And finally, we're looking at psychiatric disorders as a risk factor. So having either a mental health disorder or a substance use disorder increases one's risk for having the other one, like mental health versus substance use. And it's hypothesized that this is a bidirectional relationship, such as, for example, the self-medication hypothesis of using substances to cope with a mental disorder, for example. And beyond that, there are also some shared environmental and genetic risk factors, like I said, the externalizing and internalizing, or like stressful social situations, especially in childhood. And substance use disorders are highly comorbid with other mental health disorders, and comorbidity is associated with greater severity of the disorders and lesser likelihood of remission. Thus, why dual diagnosis treatment is very important. So in terms of identification of substance use disorders, only a fraction of those who have a substance use disorder seek treatment for it. Since they're more likely to seek treatment for physical health conditions, screening is very important. Pre-addiction refers to the early stages of a substance use disorder, such as the DSM-5's specifier of mild substance use disorder. And this pre-addiction phase is kind of a focus in screening and what they're trying to identify and intervene early before it can progress into like a more severe substance use disorder. Some common screening instruments are the ASSIST and the TAPS. There's also the view of substance use disorders as chronic disorders with onset, remission, and relapse. There's an increasing understanding of substance use disorders as chronic due to changes in the brain and associated mental health and social effects. The majority of people with substance use disorders fluctuate between remission and relapse, and long-term substance use treatment is correlated with the best outcomes. There's also the chronic care model, which was developed for chronic conditions like diabetes, and it's been proposed for substance use treatment. This chronic care model involves continuous care, so not just like trying to treat you once and you're done, you don't need to come back to treatment, whereas more viewing the disorder like a lifetime disorder. Like, for example, you wouldn't just kick someone off of their diabetes medication thinking that they're better. You would recognize that they, need that medication for an ongoing chronic period of time. Um, and it also involves tiered care of adjusting your approach according to whatever stage the individual is in. So I'll share a little bit about my own clinical experiences. In the past, I worked doing case management in an addiction medicine clinic, and I remember my supervisor. She was a primary care physician. She would often make the comparison to diabetes to the patients, because a lot of the patients there were on buprenorphine, which is a partial opioid agonist, basically just a medication for opioid use disorder, to help with their cravings, etc. And a lot of the patients, when they would first come to treatment, were very set on like, I want to just like take this for like 3 weeks and then I will just go off of it and I won't want to use anymore, and stuff like that. And they had a real desire to just kind of be rid of like any substance, even like this medication. I'm not sure if it had to do with the fact that buprenorphine is itself an opioid. But anyway, and so one of the approaches that the primary care doctor often took was she would make the connection to diabetes and explain like, well, if someone's on diabetes medication, you would just kick them off since they're doing well, for example. Um, but that's really a pattern that I noticed among the patients of them not really recognizing the chronic nature of addiction and how the disorder, you know, it's not just a one and done kind of deal, and that I believe that oftentimes that can result in them kind of cutting off their treatment early just because they want to be done with the disorder. They don't even want to be on medications for the disorder because they want to just be like totally like clean, quote unquote, from everything, which is a stigma-laden word. So I was just quoting them, but and that's also something that I've noticed at my current externship as well, a desire when veterans join the program that they often initially just want to like give it one good run and they're done and they never deal with cravings again and not really having that awareness of the like the cyclical long-term nature of addiction. So with all that, that brings me to the discussion question. So, have you all recognized this or, excuse me, encountered this at all in your clinical experiences? And if so, why do you think some individuals with substance use disorders have difficulty accepting the chronic nature of addiction? What are the pros and cons to the individual when they have this misconception? What interventions can clinicians implement when an individual is attached to believing that they can get rid of their addiction once and for all and do not seem to recognize nor accept the chronicity of the disorder? What are some factors that the clinician should take into account in that intervention? Okay, well, thank you, and I look forward to your discussion posts.